Hi everyone, thank you very much for joining. My name is Jacob. I'm one of the co-founders of accuRx. I'm really excited to be hosting you for this webinar this evening. Thanks for joining at the end of the day. Really excited with the speakers we've got, and my colleague Annie's going to go into more details at the moment. Just want to really quickly say up front why we're doing this. So we've been fortunate over the past few years to spread quite rapidly in GP practices and give them easier ways to communicate with their patients. And it's only really over the past 6 months that we've had a much bigger focus on patients as our users rather than just healthcare staff. And there's a lot of talk about as digital takes off, making sure that different groups aren't left behind, whether that's groups with disabilities or who don't speak English as a first language, or all sorts of other groups of patients. Really important, often they're the most in need of great access to healthcare. So something we care really strongly about, which is why we're doing this. And I will hand over now to Annie, who's going to tell you a bit more about what's coming up. Thanks very much.
Thank you. Hi everyone, my name's Annie. I'm a user operations specialist here at accuRx. So just wanted to reiterate what Jacob said and thank everyone so much for joining our discussion on digital inclusion and accessible design. We're really excited to be having this discussion. We know how important it is to make sure patients continue to access care digitally, and we're really grateful to be joined by experts in the digital inclusion space who will share their knowledge on the issue of digital exclusion and talk more about what we can do to make sure that patients can continue to engage in their care. So just want to say a massive thank you to all of the panelists who are joining us, and we know how busy you are and really appreciate you taking the time to share your knowledge. So on behalf of the accuRx team and all of our users, thank you so much for joining. So before we jump into questions, I'm just going to ask all of the panelists to introduce themselves and talk a little bit about their experience. So everyone will have 2 minutes, and just to help you stick to time, I'll hold up this sign when you have 30 seconds left, and this 10-second one when you have 10 seconds left. So we can go ahead and get started. Karen, would you like to introduce yourself first?
Yeah, thank you. So I'm the strategic lead for social value work in health at Manchester Health and Care Commissioning. So we're a partnership organisation between Manchester Clinical Commissioning Group and Manchester City Council, and that incorporates all adult health and social care commissioning services. And I guess the wider context is that we have, I think, the largest trust in the country with Manchester Foundation Trust in England, and Manchester Local Care Organisation, which is our neighbourhood delivery partner. We also have 85 GP practices in the city and 14 primary care networks. And as most of you who will have been to Manchester will know, it's a very big, diverse city. So I'll talk a bit later about some of the challenges and opportunities that brings for us.
Great, thank you, Karen. Victoria, would you like to go next?
Thank you. Hi everybody, my name's Victoria Betton. I'm with Mindwave Ventures. We're a small digital health company based out of London. We're a spin out from the NHS, and we help the NHS solve problems, use digital technology to do things differently and better. Our core product is a personal health record, so helping patients and citizens communicate, access and control their data and so on. My background, I'm a social worker originally by background, worked in the NHS for a gazillion years before I joined Mindwave, and most recently ran a digital health consultancy called Habitat that was owned by the NHS. I'm doing quite a bit of writing about COVID at the moment, so very interested in this topic, and I've previously written and researched quite a bit about children, young people with mental health problems and issues like digital inclusion and exclusion. Thank you.
Great, thank you so much, Victoria. Emma, would you like to go next?
Yeah, hi everybody, I'm Emma Stone. I'm from Good Things Foundation, where I'm the Director of Design Research and Comms. Good Things Foundation, if you've not heard of us before, we are a leader in digital inclusion. So we're a charity, we're based out of Sheffield, but we work across the UK. And I think there are three main things that we do. So one is that we provide free online learning to help people take their first and second and further steps online. So there's a platform called Learn My Way. Given that this is about health, it includes modules, for example, on how you access GP services online, how you access the NHS website, alongside a whole load of other supports about how you stay safe online. And we also support a network of really they're independent, diverse community organisations, libraries, social enterprises across the UK. And what they have in common is that supporting local people to get digitally included is either that much or that much of what they do and what they're passionate about. And the third thing is that in partnership with different community organisations, we deliver programmes of digital and social inclusion. So whilst we talk about digital, we're all about people. We're about people, not the tech, and about enabling people to benefit from being digitally included.
Great, thank you, Emma. Alina, would you like to go next?
Yes, so hi everyone, I'm Alina Baig. I'm one of the product engineers here at accuRx. My background is around kind of building UI for consumer-facing products. So a lot of the focus in that is on making sure that the product really is accessible to absolutely everyone who wants to use it. And so I've done a little bit of formal study around that, as well as leading accessibility efforts in some of my previous workplaces. And so I also bring that to the work that I do here at accuRx.
Great, thanks, Alina. And last but not least, Laura.
Yeah, hi, I'm Lorna. I'm head of user research at accuRx. So I work alongside Annie, Jacob and Alina. My background is in behavioural psychology, human factors and patient safety. And I joined accuRx back in 2017. My role since then has been mostly focusing on keeping our users, so both frontline NHS staff and patients, central to what we build. For people who are less familiar with what a user research does, they focus on really understanding the people that people are building software for, to make sure that any products that are released is both like useful and usable for users. And so a really big part of my role involves ensuring that our team really understands the NHS and how it works, as well as just the everyday experiences of staff and patient groups that interact with it, so that we can make sure whatever we design really works for all of our users.
Great, thanks, Lorna. Cool, and we are right on time. So we're going to kick it off by talking about why digital exclusion is a problem. And so Victoria and Emma are going to speak about this. Emma, would you like to go first?
Yeah, sure. So digital exclusion, I think, has really been exposed through lockdown in terms of the nature and the scale and significance. So we've been working on digital inclusion for over 10 years, but honestly, it's been through the pandemic that so many more people have come to realise the role that digital plays in their own lives, and what it then means when you find yourself disconnected from that or struggling to access it in different ways. So a few headline stats. These are kind of 2020 releases, but from 2019 data. 1.9 million households in the UK are offline. They don't have internet access. Interestingly, and maybe contrary to what people would imagine, 44% of those who are offline are under 60 years old. So we tend to think a lot about age, but actually it isn't only around age. And you are at least three times more likely to be either digitally excluded or offline completely if you are living in poverty, if you are facing different challenges in terms of disability and impairment, if you have a low educational attainment. And I think that goes to the point of digital exclusion is actually a problem for health inequalities. It is, I think, not only inseparable from some of the wider social determinants of health, it is almost now of that status that it is in its own right a social determinant of health, both in terms of the acceleration of digital transformation in health services and in access to healthcare. And we can expect this to continue at pace beyond the current pandemic, but also in terms of all those different aspects of our lives, about your ability to earn and to learn and to access benefits and to bank and to buy online groceries and to stay connected with your loved ones where you are locally as well as across the world. And so in all of those ways, that's why digital exclusion is a problem. It really risks widening and deepening existing inequalities, and it locks people out of a whole range of benefits. And so this is one of the frustrations, I think, that some of the people who could almost most benefit from what digital has to offer and makes often freely available are the people who are least likely to be able to access that.
Great, thank you. 30 seconds early. Victoria, would like to expand on that?
Yeah, I mean, absolutely agree with everything that Emma said. And I guess just to reinforce, and I think COVID has really shone a light on the fact that it's becoming increasingly hard to participate in everyday life without digital access in all the ways that Emma describes, and government and NHS services are increasingly expecting us to transact with them online. So having digital skills, having digital access is increasingly more and more important. We know, as Emma said, that digital exclusion is associated with social exclusion more broadly. And I guess the thing that really concerns me in an NHS context is whether we're going to further compound the inverse care law, and that is the people that need the services the most are the least likely to get them. And if we create digital services designed and orientated around the people who are most likely to use them, then we're going to further leave behind the people that need that care the most. So, and you know, the NHS is all about universal services free at the point of demand. Excuse me. So we've got a real issue and a concern. And for me, I don't know whether Emma would agree with this, but never has digital exclusion been more in the spotlight as well, actually, during COVID. So I think that's very welcome that it's really amplified the issues, and hopefully we can do more to address them.
Great, thanks, Victoria. I'd like to now just hand it over to Karen, who can speak more about the issue that you're seeing in Manchester.
Thanks, and I think I'm going to also follow on nicely from what Emma and Victoria have said, because again, this is what we're seeing in practice in what, as I said earlier, is a very diverse city where we already had huge health inequalities between the most affluent and most deprived wards in our city. And I suppose if I tell you a bit of the story, the background to the work that we're doing now. As we're part of this partnership, we're a Marmot City in Manchester. So MHCC, as a health commissioning organisation, is part of that collaborative partnership approach to addressing both the health needs and the wider determinants. And so pre-COVID, we had a lovely plan around primary care digital transformation, which we thought was quite ambitious. So we thought we would, by next March, have increased digital take-up increased take-up of digital services within primary care. Obviously, the benefits there are around increased efficiency, and for some people that would have increased access. So we are a city with a huge number of graduates, undergraduates and postgraduates, so lots of people who are already digitally enabled. However, we know that we have at least 27,000 people in the city who are digitally excluded, and we know that the issues that Emma's mentioned in particular around poverty play a big role in that, as do skills. So we've got some of the most highly skilled people in our city, but also lots of people low no skills. And we've also had a really stubborn figure of around 30,000 people in the city who have been out of work for a health reason for decades and decades. So people who've had no reason to really engage with digital services, to I suppose oversimplify. So really, what we've done in terms of planning for digital transformation was to do an equality impact assessment of our programme, as we do with all our programmes, And through that, we'd capture potential inequality of access. Again, we're talking about some older people, disabled people, speakers of other languages. I think Manchester's now got more languages spoken than any other city, certainly in the country and possibly internationally. But having done all of that lovely work, obviously COVID came along and overnight we switched to digital by default. And that has, we know, left a massive inclusion gap. And again, as Emma said, the emerging evidence is that this is actually widening inequalities for certain people. So those people who, through the work that Public Health England has done around disproportionate impacts of COVID-19 on certain communities, so Black and Asian minority ethnic communities, people living in poverty and disabled people in particular, we know that they are struggling to engage with primary care in some cases. We have an engagement team who work with patients and public and do surveillance work. And so they engage with a wide range of voluntary community sector organisations such as the Black Health Agency and disabled people's organisations. And very quickly we were starting to see evidence of people not being able to access primary care. We had, stories of people actually giving up trying to contact primary care because they just couldn't deal with it. And actually, having seen, as everywhere across the nation, a drop in attendance at accident and emergency, we had started to see a bit of a rise in people presenting at Manchester Royal Infirmary and other acute places because they felt that their GP practice wasn't open to them. A misconception, but actually it's probably partly because of that digital access. So what have we done to support people in Manchester to access primary care really is the universal gateway for all health and care services in the city. So the initial focus was on training staff, practice staff. We've got providers working with us in the city to work with GP practice staff. We had to get equipment out to staff. And then very quickly we were able to revisit the actions that we'd identified through our equality impact assessment. And because we already had an existing working relationship, because of this partnership that we consist of in terms of us being partly Manchester City Council, we quickly re-engaged more urgently with the City Council and other partners around what they were already doing on digital inclusion. And so they got involved in things like the community response hub for the city, so mainly for shielding patients, and they started to work with other partners across the city, so adult education providers, library staff who couldn't do their normal jobs, to help people to get devices, working with Good Things Foundation, and also to get that help to go online. And we have got, brilliant range of volunteers in the city, so students from Manchester Metropolitan University, Barclays, Digital Eagles, and some of these staff, as I say, who weren't able to do their normal jobs. So, very quickly we were able to put in place some really good immediate support mechanisms for some people. We've been able to build digital inclusion into our COVID recovery plans. And at the moment, we're obviously working with a whole range of providers around restarting services. And I suppose for me, though, the issue is that it's not necessarily that well known, the extent of the digital exclusion problem that we have, and particularly within acute settings. I don't think necessarily there's that connection to what's going on in neighbourhoods and what the real challenges are for people. And some of this will take time to come through in terms of customer patient feedback, I guess. So the key actions that we've taken initially have been to do an audit of all of our practice websites to check whether they're accessible information standard compliant. And we'd already commissioned some training before COVID from Breakthrough UK, Disabled People's Organisation, to do some work with practices on accessible information standard compliance. So what we've been able to do with them is shift that into digital delivery, obviously, of that training, but also the focus on access for patients will be much more around digital. And we're looking at doing something some of you will be familiar with, the Pride in Practice bronze, silver and gold standard, which works really well in Manchester and other parts of the country, around getting practices to self-assess, identify actions for improvement, and then address them collaboratively and have champions to work together on some of these issues. We also got some communications out as quickly as possible Firstly, just to reiterate that message that after the initial few weeks, there were alternative access routes for those people who weren't digitally enabled and who might never be, if we're honest. And then we also included a lot of guidance around some of the support that practices could put in place around things like the inclusion of a third party within a video consultation. How do you include an interpreter? What do you do about advocates? What are the safeguarding issues that we need to consider around domestic violence, for example, when somebody's on a video consultation? Medium term to long term, I guess, we're working with adult education providers through the city's work and skills and adult skills strategies to develop health contents within adult education provision. So again, some of the stuff that Emma mentioned about Learn My Way, similar stuff to that. So it could be drop-in sessions that people attend so that they can just learn how to get onto patient access. But longer term, there's a digital rights built into the adult education curriculum now. So we're building that health related digital content into the curriculum for all learners, including people who speak English as a second language who are going through ESOL provision. We've managed to secure some further funding for devices. We're working with the City Council, housing providers and other partners around how we prioritise allocation of those devices. And again, we're trying to think ahead to potential lockdown a second time for shielded patients. How do we prioritise those who will be able to use those devices for other reasons? Again, Emma and Victoria mentioned the fact that digital inclusion opens up so many doors and has an impact on your income. So ideally, we'll be helping people to find work again and build up their skills. We'll be working with primary care networks to identify digital leads linked to our neighbourhood delivery of services. But really, this is just the start because we need to properly resource and develop our evidence base. We want to co-produce some of the support that's needed for people out in our communities with voluntary sector organisations. We've recognised that through COVID, we've not been the best necessarily at always acting on the information that we've had from voluntary community sector organisations. So we need to really build in what they're telling us into the design of our services. And I guess our aspiration is really to improve digital inclusion at scale to support our recovery plans. And it's a really way in which health services can contribute to Manchester people's improved outcomes overall. So those health outcomes, as well as the wider determinants, and to help us all to make savings and make better use of our resources.
Great, thank you so much, Karen. That extra context about what's specifically going on in your city, I think is really helpful for everyone to hear. I'm just going to quickly break. So a colleague just sent me a quick message just to remind everyone that the questions in this panel are preset. So we won't be able to tackle all of your questions on our panel tonight, but I have a couple of colleagues who are still going to be answering any questions you have over the Q&A function. Great. So Karen also mentioned Good Things Foundation, which Emma works for. And Emma, I was hoping that you could kind of just add on to what you're doing at Good Things.
Yeah, sure. Really happy to. So I suppose, like I was saying earlier, at Good Things Foundation, we're all around people rather than the tech. But what I think has been really striking for us around the pandemic is that overnight, one of the big ways in which we work and we support community organisations to work was suddenly shut off, because actually we really believe in being able to blend digital with community, and it's not digital instead of face-to-face. And the best ways for people to learn and build their digital skills and confidence are in really hyper-local places. They feel welcome, they feel trusted, people speak their language, people make them feel at home. And so actually that's been a really, really massive shift for us, as Karen was talking about. And you know, overnight, just awful stories of people who would have regularly gone in to access the free Wi-Fi or be able to use the computer in a local community organisation. You know, there's a mother called Firuza had come over from Iran to Northumberland 8 months ago with her family, a disabled member in her family, 2 children, and that was it. The school shut, the community centre shut. She just had no internet access at all. And so Karen, you mentioned the work around devices, and I think that's one of the things that we have been, and you know, alongside others, trying to support, raising money in order to be able to get devices and also data to people, because actually that's another big issue. If you are in poverty, you cannot afford the contracts that mean you can get really great tariffs. It's part of what some people describe as the poverty premium, where if you're in poverty, you end up paying more because you can't afford the commitments to then get cheaper options. So I mention that because it didn't used to be that we would talk a lot about access and the importance of personal access and the importance of data, and that's been a real shift for us. What we also really underline though is it's not just about the device you have, it's also about the skills and confidence to use it. And I think there's a really interesting and important area here when we're talking about health and access to health services and support and well-being, which is, I think, within the health sector, people might talk about health literacy. And again, that's associated with poorer health outcomes. And how do you ensure that access to information is not only accessible in terms of maybe impairments, but also is at a good reading literacy age, and that people can really understand it and act on it. And so I think what we need to start talking more about is now digital health literacy. It's bringing those together. It's, have you got the digital skills as well as the knowledge and understanding to be able to access health services and be able to access that online, avoiding fake health news, for example. So I think that feels as though that's a really important area which I don't feel people are yet adequately grappling with. And we also talk a lot about just the confidence that comes from being able to, you know, use digital over time and being able to do that safely. One of the things that I think has also emerged more powerfully is concerns around people's data. And certainly I was having conversation with someone last week from a community organisation which supports people from refugee communities and asylum seeking communities, and some real concerns around using health online and what that means for personal data sharing and what that means in terms of data sharing across, for example, different government departments, and just a real anxiety about surveillance and issues of trust there. So it's, I just think there are so many important elements that that really need to be understood more. But what we can practically do is, as Karen was talking about, is how do we not only enable people to have the access that they need, but enable people to have the support that they need to navigate the world of online health services and be able to kind of test that out and try that out. And I'm hoping that at some point Victoria and others from the accuRx team will say more about the co-design side, because some of what we need to do is make sure that right from the start the digital services are designed with people who have low and limited digital skills in mind, to avoid then it being just another barrier you have to help people through. So that upstream end is really important. And then in the community, one of the approaches that we've evolved through work we've done on a programme called Widening Digital Participation, which was funded by NHS Digital, ended just as lockdown was starting, not for any other reason that was the natural end of the programme. But I can share a link on the chat for people who want to find out more about that. But one of the models that emerged through that was how you might use existing community assets like libraries, like community centres, to be digital health hubs. So they're places where people can go to get support, to be able to build their skills and confidence in making the best use of online GP services, online health resources, but not only online. That's often a gateway as well to finding other locally available support as well. This is not a it's online or it's offline. It's how do you better access the support you need, because quite often the people that we're talking about who are most likely to be digitally excluded may also be the least well served by our existing services and provision.
Great, thanks, Emma. I thought you brought up a really good point about the combination of health literacy and digital literacy, and how they can really depend on each other, especially in times like this. Victoria, would you be able to speak a little bit more about how inclusive design plays into this, and what inclusive design is, and also what kind of processes fit into this definition?
Okay, so for me, inclusive design is about building really deep empathy, and it's about designing with and for people who are going to use a digital service. And we often think we've got a load of facts, but they actually turn out to be hypotheses. So it's always challenging and testing assumptions. And where we think we've got a fact, testing it with the people who are intended to use that service. And there's a load of different ways. And I would call myself an enthusiastic amateur. So I'm not a designer by background, and you've got some amazing designers on the webinar. But for me, it's about drawing on desktop research. So what's already out there, what primary research is already out there that we can draw on to inform our thinking. But then it's about doing deep user research sort of in the field. So that might be things like interviews and focus groups, but it also might be ethnography. So it might be spending time with people in the settings where they are, understanding how they use technology, for example, in their everyday lives, and actually doing the same with health and care practitioners as well, because they're often the gateway to a digital service when we're looking at things in the context of the NHS. And then it's about relentless user testing. So going back all the way through that design and development process and testing out designs, user interface, user experience with people, and getting that feedback and responding to it, and obviously seeking out people who you're concerned might be excluded from that digital service. I also think it's about building trust through design. So I always remember many years ago, in my previous role, we did some discovery for an NHS client who wanted to develop a mental health website for teenagers with mental health problems. And they made an assumption that the NHS logo would be a way of creating trust. And that is often the case, actually, that an NHS logo, because the NHS is such a trusted brand, confers confidence. But when we did the user research with this group of young people, what we found was that the NHS logo was a symbol of sort of authority, and actually the young people were less likely to go on the website if they saw the NHS logo, because they were concerned that they might in some way be tracked, or their parents might be told that they'd been on that website. So there's that real sort of nuance and subtlety of that you develop through doing user-centered design. I think it's also, though, about thinking a little bit more broadly than individual users. I think we need to think about communities, need to think about society more broadly, and we need to think about unintended consequences. And there's some really neat little tools out there that can help you think in a design and development process about how you might avoid unintended consequences. So .everyone have got something called the consequence scanner, which helps you build in considering unintended consequences. And also the Open Data Institute has got the data ethics canvas that helps you look at some of the ethical implications of how you might be managing data as well. So I think there's something about using your creativity, about drawing on those sorts of tools. And then there's things like the NHS digital design standard and the government digital service. So there's some really well established principles and processes for doing really good user-centered design. But the main thing is deep empathy, and don't just go with users that are easy to access, but really spend time trying to understand users that might find it harder to access services and what their challenges and problems are and how you can help solve them.
Great, thank you so much, Victoria. So staying on this theme of user research and design, I'm going to pass it over to Lorna, who's our head of user research here at accuRx, to speak a little bit more about this and about the processes we go through and how your findings influence our design decisions at accuRx.
Yeah, sure. So, I mean, I think a lot of this aligns with bits that both Victoria and Emma have already touched on, and echoes quite a lot of what they said, especially around, I think that bit around empathy is really important, really interesting. So yeah, I mean, at accuRx, we really want to put the users at the core of our research and design process. Like the NHS, we know, is an incredibly complex organization, and it's important as a company building for that we really understand and empathize with like the underlying complexities that our users face. Without having that, we'd likely build products that are just not very useful, or maybe only useful for a specific cohort of patients. So it's really important that we do that. A really simple example of something that we've done recently when we were building our video consultation feature was in GP practices. We created a way that you could initiate a video call from your desktop, but actually then do the call from your smartphone. And this is because we knew, after spending lots of time in GP practices, that actually a lot of them didn't have the hardware or the webcams to actually get up and running with video calls. And of course, all of this changed pretty quickly at the start of COVID. And so we made the decision to change the way that we approach that, so that you could do it from a smartphone without exposing the clinician's personal details. So yeah, just a little example there of how that kind of informs how we build. But I guess in terms of our process, yeah, like I said, we spend lots of time with our users. When we were building Chain, spent 3 months in a GP practice, like just shadowing everything. And again, like we've already talked about, like really building that empathy for our users and really understanding their experience. So yeah, we spend lots of time speaking to our users, interviewing them, shadowing them, and doing lots of that ethnographic research to really just get an in-depth understanding into how something works, what the existing processes are, where they have pain points and problems, and then ultimately understanding where we could help with some of that. So as a team, we do that, and then we take some of that back and come up with different ideas of how we could potentially help with that. And again, this aligns with some of the stuff we talked about. We would then bake up some basic designs or prototypes, which then we go back to our users, get those things in front of them, get their thoughts, get their feedback, and do some of that almost like co-design process. And hearing that feedback and watching them interact with it is just incredibly helpful. It means that you can like really quickly learn if something is just not useful, whether it makes sense, what's obvious, what's not, if it fits with how they would go about doing a task or a process. And we can take all of that information from the patients that we test with or the GP practices that we work with, and then iterate on what we're building before we actually build it out in full. And so it really feeds into that kind of like the design process. So yeah, it really allows us to, on the whole, just make much better product decisions. Going back to what we talked about the who you research and you test with, obviously it's just really important from a research perspective that when we do research and testing, that we're doing it with patients who are representative, and we're not picking, like what we said, the particularly tech savvy ones are the ones who are keen to be involved in research. And so from the patient side, which we're trying to do a lot more now, when we're recruiting patients, we do it through a company, and so we make sure that they are recruiting from a wide range, different types of demographics, but also different comfort levels with technology, so that we make sure, that we're testing with lots of different types of patients. And again, on the GP side as well, exactly the same. We don't want to just test with the kind of like early adopter practices. We want to test with lots of different roles from lots of different practices all over the country, to make sure that we're not building something that's like very specific and not designed to like a wider range of needs. Something we've been focusing on more on the patient side more recently, that I think some of this like co-design and like user research feeds really nicely into the kind of inclusive design process, is around we've recently built something called patient triage, which allows a patient to initiate contact with a GP practice. And we've done lots of research with patients and testing, and then also done a bit of work around some, like there's lots of good I guess, standards and guidelines around accessibility and design. And so some things that we've been able to do to improve the accessibility for the patients are do things like increase the contrast of our text, which really helps for patients who are visually impaired, and have larger clickable targets or buttons for patients who have lower dexterity, to make it easier for them to click. We also try to use very simple words to describe actions and to make sure that we're accounting for the national reading age. We only have one key action per page, which reduces the cognitive load, which is really important going through. And so those are some of the things that we did on the screen. But then in the real world as well, we also know that patients often might not be able to do something like fill out an online form themselves. And so we made it such that somebody else could potentially do it on their behalf. So somebody like a carer or potentially a guardian, or even a receptionist in the GP practice. So doing things like that really increases the kind of availability and the reach of the product to different patients. And another thing that we did was we tried to only ask for information that is readily available. So something that we've learned is that quite often patients don't have easy access to their NHS number, but it is often used for them to access certain services. So we've avoided using NHS number, which means that they don't have to remember it. If they have mobility issues, they don't have to get up and try and go find it like on a letter. So it means that they can kind of like complete their task and like get in touch with the GP practice without having to have a lot of like preparation. But yeah, so I guess to sum it all up, by kind of like having that approach to research where our users are really involved and we use that to really iterate on our designs, we've been able to build products that are really designed around what our users need, and continue to try and prove that and make sure that we are really building for the wide range of users and not just like specific cohorts.
Great, thank you, Lorna. And yes, you talked about our new patient triage feature that we're testing right now, and kind of ways to keep patients engaged as they go through that whole process. So I'd like to pass it to Alina now, who can just give some kind of tips and quick wins for practices with patients accessing their website, or just just generally little things that users can do to help their resources be more accessible.
Yeah, so Lorna's already mentioned some great things, having larger text on websites and having like strong color contrast between the background and the text can be really useful for people with visual impairments to be able to read things a lot more easily, and having buttons that are large enough for people without fine motor skills to be able to click them without too much difficulty. Language is also definitely important. So people have different levels of cognitive abilities, and it's important to use language that everyone's able to understand. And especially for people who might be using translation within the browser to access your practice's website, it might be easier for them to be able to translate text, and that'll happen a lot easier if you're using much more simple language. It's really important to have things text-based when it comes to important information. So you wouldn't want to have image like banners and things with important information about the practice. You would want that in text so that people who are using things like screen readers that will read out the website to you out loud will be able to access that information as well, or people who might want to translate it can take that into the translator and copy that into there and get that translated. So the kind of digital consultations and things can also be quite new to people. And so a really useful thing is to be able to set expectations for people around what that will look like. So things like if they're submitting queries online, how long will it take to get back to people, so that they understand how long they might be waiting for a response. And kind of having some guidelines around what digital consultations might look like. So for somebody who might have a bit of anxiety around how that might be different to going in to see the doctor, it can be useful to understand how video consultations will take place, how long they might be, what that will look like, just kind of end to end. Lorna definitely touched on this, that we allow people to fill in forms for other people, which can be really useful for people who are less confident with technology, or who might have other people in the house who they'll trust a lot more with being able to fill these things in. They might feel more comfortable with that. And it's definitely useful to think about what people might have on hand. So things like NHS numbers, people wouldn't have those to hand necessarily and might not want to get up and go and find it somewhere. But things like name, date of birth, these are all things that people are much more likely to be able to fill in a lot more easily. And so it's good to be able to ask for information like that. In terms of like accommodating translations, that's a really key part for a lot of people with accessing care. So somebody coming in who doesn't speak English might have a translator. And so with our video consultation product at accuRx now, you can add a third person into a video call, which might be a translator for language, or if somebody is deaf, it might be somebody who can do sign language. And it's important to consider the tech and devices that people might have. So the other people here have touched on this as well, that a lot of people might not all have high-end smartphones or something. At the last count, only 80% of people in Britain had a smartphone. And so using something that means they have to use a smartphone already excludes 20% of the population. So using something like SMS will kind of bring people in who might have older devices. And there are people who are more comfortable on the computer, either because they're newer to having a phone, or they need a larger screen with which to be able to access things. And so with our video consultations, now you can send the links via the computer and people can access that through the computer as opposed to on the smartphone. And this is something that people might be more comfortable with, sitting in front of a computer than holding up a smartphone for a longer period of time. But in terms of overall things for practices to do, I think the most important thing is to kind of consider the breadth of different experiences that your patients might have in terms of different accessibility needs, and to really think about the accommodations that you might already be taking in the practice to help them, and then use that as a springboard to make the same accommodations for them digitally.
Great, thank you so much, Alina. That's all really interesting. So yeah, and thank you for all these kind of quick wins that you shared. Lorna, do you just have anything to add to that for our users? Any kind of hacks or quick wins just to help with this issue of inclusion?
Yeah, definitely. I mean, Alina already touched on being able to, for a video consultation, add in an interpreter or a carer, so you could do that, and already touched on the fact that we had quite a few patients who were struggling on their smartphones with a video call and wanted to be able to use a laptop or a tablet. So we're now releasing the ability for you to be able to email the video consultation instead of texting it to their phone. But there's a few other things. So around translation, that's not something we currently support, but we do support non-Latin characters. So if you are writing text to patients, you can actually write the text in another language, or you can paste it in to send to the patient. So that, in that sense, yeah, you can support different languages. And then we also have a bunch of support articles that I'm sure we can share after the webinar, which patients find helpful. And I know some of our GP practices often save them as templates in messages and send them to a patient who might be a little bit less tech savvy and need a little bit more help in doing certain things, like maybe taking a photo of a rash and uploading it. So there's like a helpful article that our support team has put together that you can save as a message template and then send to the patient in advance.
Great, thank you, Lorna. Great, and we are right on schedule. So thought it would be great if we can just go around the panel and talk about how we can kind of measure the success of these different projects that we've talked about, and any final thoughts. So I'll go in backwards order this time. Alina, if you'd like to go first.
Yeah, I think the kind of easiest measure of success is often just feedback. And so here at accuRx, we definitely get a lot of really great feedback from patients. Just recently for our patient triage, which is when people are able to contact their practices digitally, we recently had a 98-year-old who was able to use the form and contact their practice like that. And so getting feedback like that is a great way to know what you're doing right and know where you can improve, and the best people to tell you what they need are the people themselves. And so that's, from my perspective, is the best way to kind of get feedback around what's working and what could use a bit of improvement.
Great, thanks, Alina. Victoria, would you like to go next?
Yeah, I mean, I'd absolutely agree with the point about getting feedback as you go and in an ongoing basis. I guess as Lorna and Alina were speaking, I was just sort of reflecting on the issue of complexity. So in the consumer space, you know, if we download an app and it meets our needs, then we buy it, and it's a fairly straightforward relationship. I think one of the complexities we've got in healthcare is that you have the patient, citizen, user, you have the clinician, and then you have the buyer, and they're all different people, and they all have different needs and requirements, and that sometimes requires trade-offs. And I think that's one of the things that's often underestimated in the digital health space. So to give you an example, in all our user research, in our personal health records, patients, citizens tell us they would like instant communication with their practitioner. And some NHS trusts are up for that, but many get very worried and concerned actually about any sort of impression that they're instantly available, even though when it does get rolled out, it's usually not a problem at all. But one of the design decisions that we took on a recent personal health record implementation was to make the chat function look a bit more like email. So it's just slightly redesigning something so you get the same outcome, but you design it in a way that gives a bit more confidence and assurance to your clinician whilst also meeting the need of the patient. So I suppose it's just making a point about context and complexity and some of the trade-offs we have to make because we're trying to meet different people's needs when we're looking at digital health.
Great, thanks, Victoria. Karen, would you like to go next?
Yeah, thanks. So in addition to the ways mentioned already, so patient satisfaction surveys, monitoring the number of patients having digital video consultations, I think we're looking at, because we're looking at where we need to invest now, and really conscious of that need to invest not just within primary care but across health and social care. I think we're developing our evaluation criteria at the moment. And if anyone's got any suggestions on how we do that, I'd be really interested in hearing, because I think we'll be able to look at things like increases in skills levels across the city in partnership with the council, and it, you know, hopefully improved health outcomes. But it's complex, as Victoria said. You can't just look at this in isolation, because we need to consider all sorts of other interventions and support that's being put in place. And you know, we've got a family poverty strategy in the city, which is obviously going to be even more important than ever now. So I think we're working on it, is the honest answer. And I think we will obviously be looking at the sort of invest to save type approach that we're working on now. So by investing now, how can we improve access? How can we reduce demand ideally, and enable more patients to self-manage?
Great, thank you, Karen. Lorna, would you like to go next?
Yeah, I think in terms of measuring success, I mean, I definitely echo this stuff around like continuing to engage with users, so both NHS staff and patients, and like continuing to get their feedback and watching people like interact with something is like so incredibly helpful, and it teaches you so much. So that's always super helpful. And then I think part of it as well is through the reach of some of the things that you do. So the reach of your products, say, and the range of people that are actually able to use them. So example with Chain, it's now in over 95% of GP practices, and it's largely because Chain is so simple and easy to use, but also the technology is just really accessible to patients because we've gone with SMS. So yeah.
Great, thanks, Lorna. And last but not least, Emma.
Brilliant. I'm going to take my 30 seconds back that I saved earlier. So
we have lots of time.
4 things that I want to say. So one is at a strategic level, because I'm not sure who's in the room. Karen, you mentioned earlier about Manchester being a marmot city, and one of the things that I know came out of the Marmot City 2020 evaluation for Coventry was the lack of join up between Coventry Marmot City strategy, Coventry's digital strategy, the JSNA. So at a strategic level, I think digital inclusion has to be given proper attention, and it has to be linked into other health and well-being strategies. At the community level, I think there's a real role here, not only for health and social care, but for the health sector to support and nurture the community sector in terms of helping to build people's confidence in using digital tools around health and around their well-being. And I think at a GP level, there's also a really, I think across health professionals, we're in danger of assuming that because you're a professional in any form, that means you have the digital skills and confidence yourself. And I think the other aspect of the pandemic has been all of us are now using things like Zoom, which we may well not have been using a few months ago, and we have all had to upskill digitally. And I think there is something about, for GPs and health and care practitioners, ensuring they have the support as well to be digitally skilled and confident too. And then at that individual level of the citizen, I mean, it would be great, wouldn't it, if everyone was able to say, I feel confident to be able to use digital health support safely, and that I can use it freely. So that's a high bar for a measure of success, but there's something there about people's confidence as well as being able to afford to access support that feels really important.
Great, thank you so much, Emma. And I actually just wanted to expand on a point that you made earlier in this conversation about data costs and how that's a big factor for a lot of patients. That's something that we're really conscious about here at accuRx as well, and about the impact that it might have on our clinical users to be able to communicate with their patients, particularly around video chat. And so, yeah, we do want to let everyone on the call know that it's something we're very aware of and very conscious of, and we're investigating ways that we'll be able to reduce this cost burden. We can't say any more at the moment, but that is coming, which is really exciting. And yeah, so it looks like we're actually ending about 4 minutes early. So if there's anyone on the panel that has anything they thought of that they didn't get a chance to say, or any final thoughts, feel free.
I'll just mention, I don't think you mentioned it, Emma, that National Voices have done some interesting work around people's use of video consultations, and they've also got like a top tips thing for patients actually, so that might be worth people checking out if they'd like to follow up.
So absolutely, I've shared it in the chat panel.
Oh,
you're spot on. And what's really interesting, and it links back to the kind of point that Alina made earlier, was that one of the things they say is that actually people aren't asking for feedback from patients about their experience. So I think that really resonated with what you and others have been saying.
Great, thank you. Okay, I'll just share my screen so everyone that joined can just see the links that we have if you'd like to view this webinar again, or send it to any of your colleagues that weren't able to make it. And also, we're definitely keen to continue this conversation. We hope that it will just be an ongoing conversation that we have. So feel free to email us community@accuRx.com if you'd like to get involved. Cool, and I guess, yeah, with that, we can end a couple minutes early and can get on with our evenings. Yeah, so thanks again, huge thank you to everyone that joined us to speak. I know I learned a lot, and I'm sure that a lot of people on the call did too, so thank you.
Thank you. Bye, everyone.
Bye.
Bye, everyone.